Case 6 is about coronary angiogram with ad hoc angioplasty and stenting and critical stenosis in the coronary arteries. This is exemplified by a 42-year-old Malay middle-range factory manager with a manufacturing firm, married with 3 children. A non-smoker, he presented to me at the outpatient clinic with a central chest discomfort with feeling of dull ache in the jaw, coming especially with moderate exertion like climbing the factory staircases at work. His work involved a lot of walking on the shop floor, and he has no family history of ischemic heart disease in his sibling as well as in both his parents. Outpatient stress ECG was strongly positive with 2 millimeter STT segment depression in the anterior chest leads of the ECG, persisting and reappearing in late post-exercise recovery period. In cases like this, I don't normally bother to escalate his investigation to other non-invasive modalities such as CT angiogram because his presentation is classic and the stress test was strongly positive. Usually, I would admit patient and advise them to opt for the most definitive investigation, i.e. coronary angiogram. This patient was admitted the next day to the ward to do invasive coronary angiogram. By virtue of his history, which is classical, as well as his stress test, which showed persistence of ischemic changes in late recovery period. His lipid profile was not exceptionally abnormal. The total cholesterol was just about 6.1 with an LDL bad cholesterol of about 3.8 millimeter. As customary for my type of patient, I usually do a femoral approach. I place a one-way valve in the femoral artery in the groin, which is a relatively painless procedure. Younger cardiologists nowadays, by way of training, do it mainly from the radius in the arm. Either approach is no big deal, both equally safe in good hands. At coronary angiogram, it showed normal right coronary artery. His left coronary showed a 90% eccentric constriction in the proximal left anterior descending artery. The left anterior descending artery supplies mainly the front part of the left ventricle, which is the main so-called piston of the heart, the most important part of the heart anyway. The left circumflex, which also arrives from the left side from the left main artery, supplied the back portion of the left ventricle, and this was fairly normal, and his was fairly normal. After some small discussion with the patient on the table, he agrees to an ad hoc angioplasty and stenting. I gave him about 10,000 units of intravenous heparin to thin out his blood to prevent blood clotting around my hardware. That is, my catheters, my balloon, and my guidewires. Then I gingerly tracked up a 14,000 of an inch diameter guidewire through my guiding catheter in the groin and through the blockage and passed through the blockage with careful X-ray guidance on the console in front of me. Having passed the block, the battle is already half won. Next, I track a balloon catheter being guided by the guide wire and place it just right at the blockage in the artery. The balloon is expanded, usually up to about 10 to 11 atmospheres, to press the constriction in the thin wall artery. Next, I remove the balloon and introduce another balloon. The second balloon has a stainless steel stand or metallic alloy stand being compressed around the balloon. You can imagine the stand like the spring in your ballpoint pen. At this point, in time, it is compressed tightly around an unexpanded balloon. When the balloon and stent were exactly at the point of the initial occlusion, and when I'm satisfied that the stent limit has covered the disease portion of the occlusion, I expanded the stent balloon using an external indiflator, usually to a higher pressure, usually initially than the first initial balloon expansion, between say 14 to 10, between 14 to 18 atmosphere. Having done this, then I deflate the stent balloon and remove it. The third procedure is more of a touching up, trying to perfect the stent deployment by introducing a short non-compliant balloon and deploying it at much higher pressures. Once this is satisfactorily done, a final cine is taken. Patient is then sent to ICU or CCU for observation for a couple of hours before transfer back to the cardiac ward in the late evening. By the second day, he is ready to go home and start work the next day. In the clinic follow-up, I usually look at lipid management, aiming to bring down his LDL cholesterol, that is the bad cholesterol, to below 1.8 millimole. And secondly, I advise patients usually to reduce obesity and include exercise regime in his daily life. If he's hypertensive, I make sure that his blood pressure is well managed within the normal range. If he's diabetic, I expect perfect diabetic control because diabetes affect the heart badly. Suffice to say that 80% of my patients are all diabetic. They do badly. And from my perspective, chronic stress, I also talk about chronic stress management. This is not well discussed in the standard medical textbook, but after 36 years of practice as a cardiologist, I feel the chronic stress can impact on the heart in a bad way. Subhanallah, walhamdulillah, wa la ilaha illallah, wallahu akbar, wa la hawla wa la quwwata illa billahi al-aliyyil azim, wa la hawla wa la quwwata illa billahi al-aliyyil azim, wa la hawla wa la quwwata illa billahi al-aliyyil azim.